So hello friends, welcome to my new video. So today in this video I'm going to discuss with you all about glaucoma. Okay, so let's start. So before going into the detailed discussion on glaucoma, so first of all let me know that what is glaucoma. So as I given in this slide, the definition is like that: glaucoma is a condition which lead damage to the optic nerve, and optic nerve is the nerve that sends the image to the occipital cortex of the brain. So what glaucoma actually mean? So glaucoma mean that damage to the optic nerve, and mostly it is due to increase of the intraocular pressure. But you should remember that increased IOP, it does not signifies that the patient is having glaucoma. So it needs to be categorized in three conditions. Okay, so if these three conditions are applied, then only we can say that the person is having glaucoma, or three or at least two conditions. First of all, increased IOP. Secondly, it is a reduction of the visual field, and thirdly, optic nerve damage. So the damage of the optic nerve that I am telling is the damage to the ganglion cells of the optic nerve, and which ultimately lead to visual field defect. So if there is a damage to this optic nerve, then it will lead to visual field defect. So suppose you have a patient who is having higher IOP. Okay, like normal IOP range is in between 11 to 21 mm of Hg. So the person is having IOP of 25 or 26, but he is not having any visual field defect, and cupping is around 0.3 in both eyes. So you cannot say that the person is having glaucoma, because it is only completing only one condition, that increased IOP. But suppose the person is having a disc of cup disc ratio of 0.9 or 1, okay, and also reduction in visual field, but his IOP is normal. So at that time you can say that this person is having glaucoma, and that is called as normal tension glaucoma. So the previous condition that I was telling, that increase elevation of the IOP, but visual field and optic nerve are normal, it can be ocular hypertension. So it may lead to glaucoma in the coming days, but now the person is not having glaucoma. So here it is given how aqueous is flowing and production from the ciliary process, and how it drain out. So in our eye there is two types of media liquid is there. One is vitreous humor, another is aqueous humor. Vitreous humor is in the posterior portion of the eye. It is like a jelly which is not which do not have any production, okay. But aqueous humor, it get production from the ciliary process, and it get to the anterior chamber and move to the trabecular meshwork and drain out. Trabecular meshwork, Slam's canal, and then it drain out. Okay, so if there is any obstruction in the trabecular meshwork, as in this picture, you can see that blocked drainage channel. Okay, so the aqueous humor is getting produced from here and coming through here, but it should flow to this trabecular meshwork area. Like in this picture, you can see that the aqueous is getting drained out from the trabecular meshwork, but due to some reason or due to any condition, the trabecular meshwork is blocked, so that the aqueous is not able to drain out properly, which lead to storage of the aqueous humor, which leads to elevation of the IOP. So if this elevation of the IOP remain for a long period of time, it can lead to glaucoma, because this elevation in IOP leads to more pressure, and this pressure directly affect on the optic disc, where the lamina cribrosa getting suppressed, and it leads to cupping of the optic disc. So in both open angle and closer angle, there is a cupping of the optic disc. Okay, so let's move that these are the conditions that I was discussing with you all, that rise IOP, reduced field of vision, and damage to the optic disc. So glaucoma, there is two types of glaucoma. One is open angle, another is closer angle. These are the two types only. Okay, now open angle have several types, and closer angle can be due to several reasons. So let's discuss. First of all, this is the normal anatomy that I was discussing, that how aqueous humor getting produced from the ciliary process, how it drain out from the trabecular meshwork. And if there is any block in the trabecular meshwork, then aqueous humor is not getting produced, not able to drain out, so it get accumulated over in the anterior chamber. So this aqueous humor leads to pressure build up on the eye. So this pressure build up will lead to certain changes in the optic disc if it is not controlled at proper time. Okay, so how glaucoma develop, that I was discussing, that the aqueous humor is getting blocked, it leads to elevation of the IOP, and this elevation of the IOP, if it is long standing for a long period of time, it can lead to damage to the optic disc, which ultimately lead to cupping of the optic disc, so that the person will have visual field defect. So at glaucoma, first of all, peripheral field is getting affected, then central. So if the person is having glaucoma, he will complain that the person is not able to see the side and he can see the central. So that is called as tunnel vision. Okay. So glaucoma, there is also two types: primary glaucoma, secondary glaucoma. Okay. So primary glaucoma cause is little bit unknown, but secondary glaucoma, which is due to certain disease or any type of abnormalities, like a neovascular glaucoma, which is many times due to diabetic retinopathy or CRVO, this type of conditions. Lens-induced glaucoma means phacolytic, where the lens become opacified. So in case of phacomorphic glaucoma, lens push the iris forward so that iris close the trabecular meshwork, that leads to closer angle glaucoma. And in phacolytic, the lens substance get out from the lens, and those lens substance will get accumulated over the trabecular meshwork on the angle, which ultimately block the angle so that the aqueous humor cannot drain properly. Now uveitis lead to abnormal functioning of the ciliary process, which ultimately lead to abnormal production of the aqueous humor. So there is more production but less drainage, so it ultimately lead to pressure buildup in the eye, so it leads to glaucoma. And steroid-induced glaucoma, as we all know, that this steroid increase the IOP by increasing the production of the IOP, that means production of the aqueous humor, but the drainage is same. So that means drainage is reduced and production is more, it leads to increased IOP, and if it leads to long condition, long days, if it continues for a long period of time, it leads to damage to the optic disc, and it will be like glaucoma. In primary glaucoma, there is two types. Okay, primary glaucoma, child's and adult. Child's congenital glaucoma, juvenile glaucoma. In congenital glaucoma, it is happening at from birth to 3 years of age, and juvenile glaucoma, there is more than 3 years. So if the child is having glaucoma before 3 years of age, then the eyes were elastic. So due to that pressure buildup of the eye, so it leads to stretching of the eye. So the person, that child will lead to ophthalmos. There is bull-like eyes will be there. So that is called as congenital glaucoma. And juvenile glaucoma is if the child is having glaucoma more than 3 years, then the eye will not be that much elastic, but what to say, that pressure will build up, which ultimately lead to certain damage to the eye. Okay. In adult, there is open angle and closer angle glaucoma. So another type of glaucoma that I was discussing in the beginning of the presentation is that normal tension glaucoma. So what is the actual reason of this normal tension glaucoma is still unknown, and research is going on, but it is estimated that it can be due to abnormality in the lamina cribrosa, like overthinning of the lamina cribrosa leads to normal tension glaucoma, or hypertension or decreased intracranial pressure can also lead to normal tension glaucoma. So in normal tension glaucoma, in this normal tension glaucoma, IOP will remain constant, but there is a visual field defect and optic disc cupping can be noted. So it is glaucoma. Okay, it is a type of glaucoma. So normal tension glaucoma will like this, where there is a disc hemorrhages can also be seen. Okay. So by properly evaluating the optic disc, we can understand that is the person is having glaucoma or not. So these are the stages of glaucoma. So first of all, prodromal stage, where angle is slightly closed, and then subacute stage. It is angle is closer than stage 1. That means more closer of the angle. Then stage 1, that is prodromal stage. Acute angle closure, where there is a severe pain, redness, and loss of vision is there. And chronic angle closure, there is no pain, no symptoms, and absolute glaucoma, then that means the NPL. So if the glaucoma is very long continued and is not treated properly, it leads to damage to the optic disc also, and which ultimately lead to blindness. So at that time, the eye will be like an NOPL. That means it will called as absolute eye. Okay. So in glaucoma, mostly in the angle closure glaucoma, what happens is that the cornea become hazy. Why? Because due to accumulation of the more aqueous humor to the anterior chamber, this anterior chamber breaks the endothelial tight junction and get inserted to the corneal, okay, and it leads to edema or stomal edema, epithelial edema, like this type of same condition will be there, which lead to hazy view of the eye, okay. So in glaucoma, many patients who are having glaucoma, they are having hazy view on the cornea, okay. So how to diagnose glaucoma? So first of all, tonometry to measure the intraocular pressure of the eye. So one thing that I want to tell you, that always use Goldman applanation tonometer to measure the intraocular pressure, not NCT, not any type of other like Shields tonometer, air puff tonometer. Don't use this type of tonometer. Always you should use Goldman applanation tonometer, because it is the gold standard method to measure the intraocular pressure of the eye, okay. So another is that optic disc evaluation to see what is the amount of cup disc ratio, okay, and if it is more than 0.9 or 1 or 2, then it can be glaucoma, okay. Now optic disc OCT, that is optic disc OCT should be also be done to evaluate what is the thickness of the RNFL layer, and visual field testing with the help of Humphrey visual field analyzer. That that video of that Humphrey visual field analyzer also available in the channel, okay. So you should go and watch that video. Now, what is the management of glaucoma? There is 4 types of management are there: pharmacological management, laser use, surgical management, and cyclocryotherapy. So pharmacological management. So pharmacological management means uses of drugs. So drug have 2 type of section. One is to reduce the production of aqueous humor. Another method is to increase the aqueous humor outflow. So some drugs are used to reduce the aqueous humor production, and some drugs are used to increase the aqueous humor outflow. So what are these? First of all, let's start with increase aqueous production. Sorry, it will be decrease aqueous production. Okay, that is a mistake. So that will be decrease aqueous production. So those drugs are used to decrease the aqueous humor production. First of all, beta blocker. So beta blocker should be used. So beta blocker like timolol, betoxolol, these type of drugs are used to decrease the aqueous humor production. So beta blocker were very much popular in the past, but nowadays beta blocker are not that much used because it has some side effect also. Alpha 2 antagonist brimonidine and carbonic anhydrase inhibitor acetazolamide, brinzolamide, dorzolamide, these types of drugs are used to reduce the aqueous humor production. So the more the reduced production of the aqueous humor, then the IOP will also be reduced, because there is less production of aqueous humor and the drainage is also less or the constant way. So it leads to a stabilization or reduction in the IOP. Now some drugs, as I already told you, that some drugs are used to increase the aqueous humor outflow. So first of all, increase trabecular outflow. Here myotic like pilocarpine. So if the person is having angle closure glaucoma, then using pilocarpine will lead to constriction of the pupil, so that there will be opening of the anterior chamber angle, so that the aqueous humor can go pass through it. So that is the use of pilocarpine, myotic drug. Another is alpha 2 antagonist, dipivefrin, and another is increased uveoscleral outflow. So aqueous humor have 2 type of outflow. One is from the trabecular meshwork, another is from the uveoscleral outflow. So conventional and unconventional, okay. So unconventional pathway will also be activated, so that there will be more outflow of the aqueous humor, which lead to reduction of the IOP. So the most popular drug that is used to in glaucoma is this prostaglandin analogous, that is latanoprost, travoprost. This type of drugs are used nowadays mostly to in case of glaucoma patient to reduce the intraocular pressure. Now here there is, if the person is having angle closure glaucoma, what should you do? Suppose you have a patient. So first of all, primary angle closure glaucoma, early visual field defect is there. So in case of primary angle closure glaucoma, symptom will be different from the open angle glaucoma. So in angle closure glaucoma, there is a severe eye ache and also redness is there. So why? Because the angle closure glaucoma is many times it is an acute condition. It is an acute state, and open angle is a chronic state. So this acute state leads to sudden increase in the IOP, which stimulate the nerves of the cornea very much suddenly, which leads to severe eye ache. Okay. So if the person is having acute angle closure glaucoma or primary angle closure glaucoma, first of all, you need to do YAG laser iridectomy. Why? So why you need to do YAG laser iridectomy? Because by doing YAG laser iridectomy, you are making an extra pathway. because the angle is closed and aqueous humor cannot pass through the trabecular meshwork. So you are creating an extra pathway to allow the aqueous to pass through. Okay. So YAG laser iridotomy, and the target IOP should be less than 21 mm of Hg. So after doing the YAG laser iridotomy, if the IOP is not reduced, then prostaglandin analogous plus beta blocker plus carbonic anhydrase inhibitor plus alpha antagonist should be used. Even after using of these drugs or medication, if the IOP is not controlled, then you can try pilocarpine in addition to the above medication. So you will use this prostaglandin analogous beta blocker, CA inhibitor and alpha antagonist along with the pilocarpine to reduce the IOP. And if these are not working, then consider lens extraction if critically shallow anterior chamber depth. If this also not working, then trabeculectomy with mitomycin C. So trabeculectomy is the process to make the pathway, okay, to allow the allow the aqueous humor to pass through that flap. Okay, in trabeculectomy, a pathway is created surgically. It is a surgical procedure. Okay. Another is there another procedure if the person is having person is not treated properly with YAG laser iridotomy, or you did YAG laser IOP controlled on medical RX. Suppose you did YAG laser and the IOP is controlled now. So you need to instruct the patient to have a routine examination to the clinic in every 6-month review. Okay. So these are the some guidelines to how you should manage a person who are having primary angle closure glaucoma. Now here you can see this is the YAG PI. Okay, where there is a secondary pathway is created. Here you can see a hole. So by this hole aqueous humor is passing. So in case of posterior synecdoche or this type of condition, aqueous humor is not properly flowing to the or properly able to flow through the pupillary area. So so an extra passage is created or extra hole is created to allow the aqueous humor to get flow from this area also. Okay. Another is that iridectomy. Here this is done in the base of the iris. Okay. This is the trabeculectomy, where this is the trabeculotome which is inserted and making a pathway. So trabeculotomy is the old procedure and trabeculectomy is the latest procedure, where you can see a flap is created. So this is the surgical flap or trab surgery it is called, where there is the passage is created, you can see. So aqueous humor is coming through this area and getting stored over this fluid reservoir, and slowly it gets absorbed by the blood vessel and aqueous humor can get passed through it, so that IOP will be in normal state. So this is an procedure. Another is that goniotomy, that means by viewing the anterior chamber angle and doing surgical procedure, that is goniotomy. You are seeing the angle and cutting the some portion of the angle to make a passage or pathway, that is goniotomy. So another is that this is Ahmed valve implantation. So if the mention this type of procedure like YAG PI, iridectomy, trabeculectomy, trabeculotomy, trabeculectomy and goniotomy, if this procedure are not working at all and medication are also failed to treat or to reduce the IOP of the patient, the last option is that Ahmed valve implantation, where a valve is implanted. So this valve is look like this, and there is a pipe is fitted over the anterior chamber, so that aqueous humor can get enter to the to this pipe and get out from the eye. So this is done in a controlled manner to reduce the IOP. Okay. So this is the last option that a surgeon will choose if the IOP of the eye is not controlling at all. Okay. So that's all friends, thanks for watching, and please don't forget to like my video and subscribe to my channel, and I hope that you learned something from this video, and please don't forget to share with your friends